but who cannot have MRI for any reason. Also can be considered in women with dense breast tissue as an adjunct to mammography. Then MRI, proven carriers of BRCA mutations annually starting by the years of 30, untested first-degree relative of proven BRCA gene carrier annually starting by the age of 30 as well. Women with 20% lifetime risk for breast cancer on the basis of family history annually starting by the age of 30. Women with histories of chest radiation for Hodgkin disease starting 8 years after the radiation therapy. Women with newly diagnosed breast cancer and normal contralateral breast by conventional imaging and physical examination, single screening MRI of the contralateral breast at the time of diagnosis. Also may be considered in women with between 15 and 20% lifetime risk of breast cancer on the basis of personal history of breast cancer, ovarian cancer, or biopsy-proven lobular carcinoma or ADH. Then coming to a screening by risk factors, the guidelines based on risk factors. The average age start of annual mammogram starts at the age of 40. The high-risk group, BRCA1 and BRCA2 mutation carrier with untested first-degree relative mutation carrier, annual mammogram and annual MRI, both annual mammogram and annual MRI started at the age of 30, but not before the age of 25. Women with 20% lifetime risk of breast cancer on basis of family history, annual mammogram and annual MRI starting by the age of 30, but not before the age of 25, or 10 years before the age of the youngest affected relative, whichever is later. For history of chest irradiation received between the age of 10 and 30, annual mammogram and annual MRI starting 8 years after treatment, and mammography is not recommended before the age of 25. For personal history of breast cancer, invasive carcinoma or DCIS, ovarian cancer or biopsy-proven lobular carcinoma or ADH, annual mammogram from the time of the diagnosis, either annual MRI and ultrasound can be also considered. If screening MRI is performed in addition of mammography, also performing screening ultrasound is not necessary. Women with dense breast as the only risk factor, the addition of ultrasound to screening mammogram is effective and no need for MRI. These are all the guidelines stated in the last ACR, and then there are certain issues about debating, and there were certain arguments about the screening annually beginning at the age of 40, screening with digital mammography in comparison to analog mammogram, and screening with mammography before the age of 40 and screening after the age of 70. And also they have certain discussion about the risk assessment, MRI screening and ultrasonography screening. About the risk assessment, MRI screening and ultrasonography screening, I think it was covered by my colleagues, all the argument was covered. And now I will move to the panel and ask the panel about their opinion about screening annually beginning at the age of 40. What do they think? We'll start with Dr. Rasha. Do you agree for screening at the age of 40?
I do agree, because actually we see, working in Cairo University hospitals, we see a lot of patients. Maybe most of our patients are in their late 30s and even in their 20s as well. And I think it was a good step that you changed the screening, made it at a younger age. It deserves, I think, in Egypt. Especially that we have no studies to disprove that cancer breast occurs at a younger age in Egypt, except for one study made by the National Cancer Institute. And I think we should think about getting national statistics to the incidence of breast cancer in Egypt.
Okay. So you agree with screening with 40? Dr. Wafa?
Yes, I do agree, because this is the perimenopausal phase, and the perimenopausal phase biologically for the female is very critical. And I think it is justified to carry out screening at this age, unless there is family history where we have to go by the age by 30 or lesser.
Dr. Iman?
The only concern will be the cost effective, because you're gonna include much more population if you start earlier than 40, and the accumulation of exposure, radiation exposure, because the lady will gonna do much more frequent examinations. If we started before the 40, I think 40 is a good start.
Yes, okay.
About the cost effectiveness, most of the studies performed to assess whether it is more cost effective to do a screening programs at a younger age or just discovering breast cancer at younger age during the diagnostic context, they found that it is more cost effective to find out, to screen and find out early cancer than to leave the cancer to be locally advanced and then treat the cancer.
Yes, adding to the issue of the cost, when the breast cancer is discovered early during screening at the size of below 1 centimeter diameter, it costs about 10,000 Egyptian money to be treated. But when it is detected in an advanced stage, like stage 4 or having 4 or 5 centimeter cancer, it costs 150,000 Egyptian money to be treated, and it will die, of course.
Maybe more.
So maybe more. Yes. So for the cost effectiveness, screening is cost effective. But what do you think about screening before the age of 40?
Only if there is family history or some contributing factor to such hereditary breast cancer syndrome, breast ovarian, familial prostate cancer, pancreatic cancer. If the family history is relevant, or there is ductal carcinoma in situ, for example.
Yes, so you agree only for screening before with the risk factors and the guidelines stated before. Okay. For you are not different than the opinions given by the ACR. Evidence to support the recommendation of regular periodic screening mammography comes from the results of several randomized trials conducted in Europe and USA, and included a total of 500,000 women. The trial varied in the age included of women in screening and frequency, but all demonstrated a statistically significant reduction in the mortality among women when it reaches about 26% reduction in mortality. Studies reported also 39% reduction in cancer mortality when comparing the area of population-based screening before and after. Therefore, has been some controversy upon the age of regular screening mammography, at what age it should start. Originally chosen the surrogate for menopause, ala waqt al-menopause, and it was at that time at the age of 50. And some have suggested that the data do not support screening before that age. The evidence, in fact, does not support this opinion. A careful review of the argument shows that the suggestion that the age of 50 has any biological prevalence on screening. Nothing more can be added. The data are only artifacts of inappropriate subgroup analysis. The randomized controlled trials did not have any sufficient statistical power to permit analysis of the subgroup, yet the results of analyzing women between the age of 40 to 49 and comparing those to the data of the age of 50. Recently, the United States Prevalence Service Task Force, an independent governmental agency consisting of 16 primary care physicians and public health specialists, issued a revised recommendation for screening. Whenever they had formally recommended routine screening every 1 to 2 years starting at the age of 40, they are now recommending against routine screening from the age of 40 to 49 and biannual rather than annual for women from the age of 50 to the age of 74. They mark no recommendation for women over the age of 74. I'm going to ask Dr. Rasha, do you agree with the last statement of the United Task Force?
About the age of 74?
Whenever they recommend screening from 40 to 49 biannual and annual after 50 and to stop screening at 74. Do you agree?
I have just one comment to make before commenting on this. The guidelines that are put internationally, they should fit to every individual location. They tackle the guidelines according to their national statistics. Maybe the statistics in USA are completely different from our statistics. The age incidence and the onset of the disease is at a younger age in our countries than their countries. So I think they did not do this arbitrarily. They just, depending on what the national statistics said, maybe they found that it's of no use, and they found it not cost effective to screen babies above the age of 74 and below the age of 50. But I think if we have documented statistics in Egypt, we can then change in the guidelines according to our needs, not their needs. So I have to agree because
you don't have to agree if you don't agree.
No, I mean that they did this based on studies at their country. We don't have studies here to document that we do screening every 2 years, especially, for example, we have a different body stature than the Americans. We have many ladies with a larger breast in which the lady might have cancer, and she wouldn't feel it by clinical or survey.
They chosen the age of 50 because it's a surrogate for menopause, but actually it has no biological relation to cancer. Do you agree, Dr. Wafa? Why choosing 50?
I don't have a solid opinion because we know that the risk of cancer increases with the advance of age. So I don't know why to minimize the frequency of screening with the advance of age. This is number one. Number two, cancers that occur at older ages are biologically less aggressive than those occurring in younger age. So it depends. I think it depends on. I don't have a solid opinion on that, but I think biannual breast cancer screening, as long as the female is living, is a good option.
Okay. But biannual is
every 2 years.
2 years is a long time. The doubling time of the tumor is faster than. I agree with 1 year. For myself, I don't agree with this statement, Dr. Iman.
I agree with Dr. Rasha. We don't have solid data to follow them. We have to make our cancer registry first, and then to put our guidelines modified from their guidelines.
Actually, these data are population-based, so consider it's a population-based, and this comes from Egypt. Still, do you agree with screening at 50 annually and biannually on 40?
I don't agree to stop screening patients because she reached 74 age. What to do with that? We have to screen every lady above the age of 40 once a year.
Yes, actually, I think screening at the age of 40 is very important because the biological pattern is different, and as all our studies here mentioned, and the practice in the centers of cancer in Egypt shows that the pattern of cancer is its early stage. So we should start at the age of 40. And also, there is a very important, significant information you mentioned in your presentation, in your first slide. The outcome of your statistics that was shown that you detected cases that's about 2.4 centimeters. There's one slide that you showed that you have mass lesions, and these mass lesions actually is different outcome compared with the outcomes in the United States and in international studies. The instance of impalpable breast lesions compared to them internationally is different. So we should probably, even in the future, might go earlier. We need to maximize the number of impalpable breast lesions and get cancer at an early stage to have a real outcome on the life of our patients. Thank you.
In their meta-analysis of randomized controlled trials, they acknowledged the statistically significant 15% reduction in mortality among the women aged between 40 to 49 screened, but states no harm was associated with screening. They also used a simple mathematical model to predict the mortality reduction achieved by various screening strategies, and when screening biannually, they preserve 80% of mortality, and reduction of annual screening mammogram starting at the age of 40 rather than the age of 50 would result in additional mortality, they claim. This is the task force. They also started the screening age at 50 rather than 40, would sacrifice 33 years life, bear 1,000 women. Despite this analysis, they concluded that the biannual screening beginning at the age of 50 would achieve most of the benefits of annual mammogram starting at the age of 40 with substantially less harm. Do you agree?
Agree.
You agree? Okay. Rasha, you agree?
Yes.
Rasha? Yes, you agree. You have to. Okay. In their 2009 recommendation...
No, I don't agree, Nakla, in Egypt, the biannual in Egypt, no.
No, okay. We are discussing step by step. In their 2009 recommendation, the United Service Task Force suggests a woman aged at 40 to 49 might want to consider their personal risk for developing breast cancer before deciding to participate in the screening program. They think there is a risk when screening before the age of 40, the risk of overdiagnosis, the risk of treating unnecessary condition. Yesterday we were discussing the high-risk lesions and DCIS. You know, there are many of about 5%, 15% of detected DCIS are low-grade, and they can stay in the woman's breast for 30 years without manifesting. So the problem of starting early is that microcalcification, indeterminate microcalcification, is a prevalent condition. It represents 30% of findings on mammography, and we can encounter many DCIS, low-grade DCIS, and low-grade ATH, and low-grade papillary lesions without atypia. And actually these lesions, if untreated, it will never manifest in life. So the United Task Force goes against screening at the age of 40 for that reason. The problem of overdiagnosis and the problem of over-treatment and the risk of operation and the risk of over-treatment, the risk of chemotherapy unnecessary, the risk of radiation unnecessary, because it will never manifest, but once diagnosis should be treated. Okay, you agree?
From your clinical practice, we have similar practice working in similar places. When you encounter a breast cancer in a young individual, do you see it in the form of microcalcifications, or most of the cases come when they are locally advanced? Most of the cases come when they are locally advanced.
For myself, I don't agree with the statement of biannual. I don't agree with screening at the age of 40. I myself started my screening at the age of 36. But I'm discussing the controversy about screening. We are discussing, it's an open discussion if any of us wants to share us. There are many authors against screening. at the age of 40. So I'm highlighting the problem. Okay. Dr. Iman.
No, I don't agree with what they say that screening earlier is. If there is any worry about the amount of exposure that a lady will take throughout her lifetime, I think the new machines, the exposure is much less than it used to be. We don't need to do re-evaluation and re-ray again like we used to do using the digital imaging. And if there is worry, we can prolong the period but not make it 2 years because most of the ladies, we encounter a lot of ladies with fibrocystic mammary changes here. I think the incidence is higher than what is there in USA and in Europe. And with the fibrocystic mammary changes, it's very difficult for any lady to identify a true malignant mass within this, within the breast. So we cannot depend on the breast self-examination and on the clinical examination.
Plus 2 years is a long period. If the lady was unlucky and she started cancer after her last mammogram, after 2 years she will come also with a big carcinoma.
With an advanced, yes.
But this implies, Dr. Nagila, this implies activation of awareness campaign.
Yes.
And,
yes, of course.
And improving the cultural milieu of the population to be motivated towards screening every year.
I believe the screening in Egypt is not a standalone business. It is the business of any healthcare provider involved in the breast cancer, either in diagnosis, treatment, laboratory, genes, surgery. Because we are a big country, we have many people. the estimated, the expected women above the age of 40, the estimated number was at the last estimation at the year 2010 was 8-9 millions. I think they are more. It can be a population of one of the European countries and more. So the screening program needs the effort of everyone involved in breast cancer health provider. None of the randomized controlled trials of screening stratified women at risk despite the identification of factors that increase risk of developing breast cancer. Most of women who develop breast cancer have no demonstrated risk other than are women and at their age. It is estimated that approximately 70 to 80% of breast cancer occur in women with no identified risk factor. Do you agree, Dr. Wafa? يعني احنا بنقعد نقول risk factor, but actually 70% of cases they came without any family history, no smoking, مخلفين 10 عيال, lactating. Sometimes we discover mammography during lactation, during pregnancy, at the age of 35. So for me, I always say being a woman is a risk factor for breast cancer.
Yes, the environmental factors are very risky. Contribute to many risk factors.
So you agree. نيجي نعمل genes. Therefore, if only high-risk women are screened, the majority of breast cancer would be missed because most of breast cancer occur among very large population of women who are not at increased risk. The revised United States Preventive Service Task Force recommendations were met with widespread concern among breast imaging community and public. The ACR and the SBI, Society of Breast Imaging, along with the ACS and other organizations, strongly cited the United Force recommendation, disagreeing with the conclusion reached by their analysis. هم ما وافقوش زينا. The ACR and the SBI firmly stand behind their recommendation that screening mammography should be performed annually beginning at the age of 40 for women at average risk for breast cancer. يعني regardless the risk, every woman should be screened at the age of 40 every year. several studies comparing the performance, coming to the second debate, screening with digital mammography or maybe analog mammography is okay. It's a technical question for Dr. Iman. Screening, digital is different than analog. Do you believe digital mammography do better than analog? So you recommend only digital?
Yes.
If not available?
If not available, خلاص, I'm obliged to go to the analog. But if it's preferable to do the screening with digital mammography.
And Rasha?
I think using the analogs now is
It's going.
it's not right at all. Yeah.
It's fading out. The analog mammography is fading out.
Okay, we will see what the trials stated. The digital mammography imaging screening trial, the multi-center study that enrolled 49,000 women at 33 centers across the United States and Canada, found no significant difference between digital and film screening sensitivity among their population. However, digital mammography performed significantly better than analog mammography in screening of premenopausal and premenopausal women and women below the age of 50. So, the ACR and the SBI feel that women should continue to be screened if digital mammography is not available in their community. So to sum up, the performance of digital mammography, of course, outperforms the performance of analog mammography, but the difference is not statistically significant above the age of 50, that's fatty breast, but the performance is significantly different before the age of 50. So, in premenopausal or dense breast, digital mammography is preferred, but if not present, screening should continue with the analog mammography. Okay? About screening before the age of 40, and I think we have a real problem in Egypt, and we all should contribute or submit a research concerning the issue of the age presentation of breast cancer in our country. I feel we must have environmental difference, or maybe genetic study will prove something that we have other than the European and American, because recently over the last 3-5 years, I think I see every day a female at the age of 20, not 30, 20. I see every day a case of 20 with breast cancer, with many of them with no family history and of course no risk. So what's your explanation, Dr. Walter?
This is the early onset breast cancer. This is most probably is hereditary or familial due to some defective genes. So we have in fact to inspect very carefully and very closely these cases, and regard and look to their family history with more importance.
Do you have an explanation, Doctor?
We see a lot of cases, and we ask about the family. When she comes as a young individual, we ask her about the family history, and astonishing enough that most of them have no family history whatsoever. And not for ovarian, not for breast cancer. They are not candidates anyway. Most of them, many of them, come during lactation or during pregnancy with a locally advanced breast cancer. I think there's something environmental maybe in the food, to my opinion, but there are no documented studies. But I think it deserves that we should do a study. Yes.
Genetic studies, because in such cases it could, mutation eventually in germline
yes,
cells. And in this case, it will be hereditary for the descendants.
yes.
It can move.
Actually, it's a problem because in the conscious and guidelines of the ACR, they stated that don't do mammography before 25. And you start mammography at the age of 30, even if families with high risk. So I think this issue is debatable here. So I can recommend MRI every year or ultrasound before the age of 20. I don't know. We are frequently asked by the mothers, do you recommend I don't know how to answer. To recommend the MRI every year? It's crazy.
We have to admit that half of the BRCA carriers inherit the BRCA from the father.
Yes, of course, the BRCA2
cancer.
Especially the BRCA2.
Yes, BRCA2. So we have also to insist on the family history from the paternal side also.
Yeah. Actually, I think again here we are speaking about the different biological behavior of of breast cancer in Egypt, and I think for those particular patients you are speaking about, cancer breast at an early age, those are the patients that need research. Probably there is another mechanism by which the gene mutations occurs, not BRCA1, not BRCA2, and maybe other determinants in the genetic profile of those patients. And I think we should search what's the role of suppressor genes at this, because those are the genes that are really affected. And actually, I've seen your slides now, P53 gene. The P53 gene and the tumor suppressor genes are not only involved in syndromes; they are actually involved in most of the cancers. Particularly the existence of the wild type and mutating to the mutant type of P53. In those particular cases, the genetic change could occur due to environmental conditions or environmental factors, and it needs to be studied. Those are the patients that should be referred for molecular research integrated to collect sample size of 100, 200, and do all sequencing, all the profile you mentioned, Dr. Awad. And I think this will be a very good study. Again,
yes.
The other, regarding the question you mentioned about DCIS, for some cases when you go to early screening, you have a higher yield with a low-grade DCIS, right? You mentioned this. Actually, here, if you take it as cancer, and if you get this surgery involved at this stage, the sequence will be surgery and excision or whatever, okay? But again, those cases need to be involving more radiological assessment and more non-invasive measures. I think MRI here is more important. Tomosynthesis, I think, should be determining which of these cases needs to be surgically interfered. I don't know. You need to work also on what are the cases of DCIS that require surgery and what others. Because most of those cases will come to us as BI-RADS 4, right?
Till now, no.
And we will be faced with a biopsy.
If I did a biopsy for you and the results come with low DCIS and it's a focus and it was totally removed by the biopsy.
Yeah.
The question is for you. What are you going to do? To re-operate? Or it's okay, fine.
No, if there is no radiological evidence of the disease, actually follow up, number one. And maybe the axillary lymph nodes, actually listening to the lectures of yesterday in the surgery here, actually even determining the axillary lymph node status as positive or negative will not actually determine the final outcome and the overall survival of patients. This is a very difficult message, but we heard this yesterday. Again, what to do is probably do a sentinel lymph node. Only. If it's negative, so follow up. So we are facing a total change in the management of these early cases.
I think this will be in the future to be considered.
But what to do with these DCIS cases with low grade need also to be studied. Maybe a randomized control study. Some of the cases will go for follow-up and others will be taking surgery, and we'll see from there.
Okay. I found this in the literature. There are other genes, actually in the recommendations as well. There are other genes involved in the breast cancer screening. Maybe some of these genes explain the status in Egypt, and that we encounter young breast cancer in young. I think the Coden syndrome, we frequently see Coden syndrome, but we never analyze and never go behind. Dr. Wafaa, we see a lot of cases with hamartoma in the thyroid and multiple adenomas in the breast. I think if we make gene assessment, it will. So other genes are involved in the breast cancer, patent genes, B53 and live ferment, and the Bitt-Jagger syndrome, which is STK11 also. And I think we have, we see a lot of these cases. Maybe it's an explanation, but it needs research. But still, there is no guidelines at that time concerning this group. Coming to the last debate to end this session, before we are, we don't want the man to miss the Jum'ah prayer. At what time should the screening end?
Shouldn't end.
75 shouldn't end.
Life expectancy now getting forward to 90 and 95. So.
Yes, it depends on the life expectancy.
Yeah.
So we are expecting the life expectancy now is reaching 58. So since you have 5 and 7 more years after 70, you shouldn't stop screening, and this is given the competing causes of morbidity and mortality that increase with age. The ACR and SBI suggest that screening with mammography should continue as long as the woman has a life expectancy of 5 to 7 more years on basis of age and health status, is willing to undergo additional testing, including biopsy, if indicated by finding in mammography, and would be treated as breast cancer if diagnosed. Thank you for your attention.
Thank you very much, Professor Nagla. In fact, you enriched this session by your approval of the guidelines and the panel discussion, and we announce closure of this session, and thank the organizers and the dynamo of this session, Dr. Nagla Abdelrazek, and my co-chairpersons, the Professor Rasha Kamel and Professor Iman Zaki, and myself, Wafaa Al-Ibnawi. Thank you very much.